Good morning, good afternoon, everyone. We'll get started in a minute. Okay, I think we've just, I can see the participant numbers growing, so we're going to get started in just a moment. See the chat box going. Hi, Edwin, nice to have you here. Hi, Olga. So hello and welcome, everyone. My name is Naomi Berkshire, and I'm the Executive Director of Harm Reduction International, and I'm so pleased to connect with you all today to share our latest results tracking harm reduction policy and services around the world. First thing to say is it would not be possible without the support of the global harm reduction community and leadership of the community of people who use drugs. To everyone we've listed in the acknowledgement section of our report, please know we are deeply, deeply grateful for your commitment to advancing the harm reduction movement. Above all, I want to commend Dr. Robert Chak for his leadership of this project, together with Sam Shirley Bevan, Suchitra Rajagopalan, and our Deputy Director, Colleen Daniels, for their work to drive the 7th edition of this epic project to the global state of harm reduction. Public health and human rights have been headline news all year for all the wrong reasons. The COVID-19 pandemic has changed our sense of safety and everything about how we operate. The murder of George Floyd united millions in heartbreak and rage in solidarity with the Black Lives Matter movement, and connecting also more recently with the anti-police brutality protests in Nigeria under the End SARS movement. These events speak directly to our core beliefs. Health and well-being, together with the commitment to see every person for their inherent human dignity, ground our everyday work in harm reduction. An estimated 11.3 million people inject drugs globally. 269 million people are estimated to use drugs. However, while 179 of 206 countries report some injecting drug use, 110 countries, that's the majority of countries, have no data on its prevalence. Stigma, discrimination, and criminalization force literally millions of people to conceal their drug use, pushing them into spaces where risks and harms are increased rather than decreased. I'm going to start sharing some slides of them to start this conversation in a more coherent sense. Can you see that? No. There we go. That's our thank you. We cannot hope to effectively plan for public health without data, and will not resolve this gaping hole in our understanding of drug use until we decriminalize drug use and eliminate stigma and discrimination. Our global state research reveals a continuation of the stalling effect that we reported on since 2014. To be clear, it's not an absolute stall. Every year we observe some positive progress and some reforms. Unfortunately, this is usually also accompanied by regression in other countries. In terms of core harm reduction services, the number of countries implementing needle and syringe programs around the world remained level at 86 countries. There were some positive changes. Algeria, Benin, Nigeria, and Sierra Leone opened needle and syringe programs. However, Palestine, Jordan, Mongolia, and Uganda ceased to operate their NSPs for various reasons. The number of countries where opiate agonist therapy is available decreased by 2 to 84 countries around the world. Burkina Faso opened its first OAT program in a hospital. However, Costa Rica, Bahrain, and Kuwait stopped OAT provision. Globally, we tracked a total of 12 countries and 3 regions where drug consumption rooms or safe injecting facilities operate, and Portugal opened its first DCR in 2019, being the new addition to this list. We confirmed peer distribution of naloxone for overdose reversal in 16 countries around the world. And just to emphasize, we track peer distribution of this life-saving medicine because it's the most effective way of ensuring that naloxone is in the hands of the right person at the right time. We need significantly increased scale and coverage of these essential services in order to respond to the extraordinarily high burden of HIV and hepatitis C amongst people who inject drugs. These top-line figures don't tell the stories of the large differences between the regions in terms of harm reduction implementation. Even where services and harm reduction interventions are available, there's often insufficient coverage, barriers to services, or issues with the quality of services. Rural communities are underserved in many countries and regions. Racism, discrimination against Indigenous, Black and Brown people create entrenched structural barriers which worsen health outcomes. Women and gender non-conforming people face considerable barriers to accessing services. People who are homeless are excluded, and the response for people who use stimulants or non-injecting methods falls well behind the services for opioid use. All this to say is we know that there's more work to do. Before I turn to our fantastic panel, I'm going to speak very briefly to 3 more interconnected points: harm reduction in prisons, harm reduction in COVID-19, and the funding crisis for harm reduction. Punitive drug policies and the demonization of people who use drugs drive mass incarceration and the overcrowding of jails around the world. This has been a disaster in the context of the pandemic, with closed settings exacerbating vulnerability not only to HIV, viral hepatitis and TB, but also to COVID-19. Despite a surge of energy early in the year around reducing prison populations in the context of COVID-19, we found that 109 countries that moved to implement prison decongestion measures, only 25% of these countries, well, 25% of these countries explicitly excluded people detained for certain drug offenses, regardless of whether they met other criteria based on their vulnerability or health status. It's hard to fathom that even in the context of grand humanitarian gestures, there are policymakers who fail to see the human beings involved and reserve special punitive approaches for all matters related to drug policy. I'm going to go back to this one. The thing is, drug use is present in most prison settings. Approximately 1/3 of people in prisons worldwide are estimated to have used drugs at least once while incarcerated, which is why, while we work towards a future where people are not incarcerated for drug offenses, we track harm reduction interventions currently available in prisons with the hope of applying sufficient pressure to reduce some of the health-related harms of incarceration. Sorry, my slides. The number of countries where needle and syringe programs are available in prisons has not changed since our last report in 2018. There are just 10 countries around the world where needle and syringe programs are available in at least one prison setting in the country. Where needle and syringe programs are available, coverage and access are generally inadequate. In 2020, 59 countries are providing opiate agonist therapy in at least one prison in the country. That's 5 more than in 2018, which is good news. But again, this is a very binary measurement and doesn't suggest there's sufficient access, quality, or coverage of this intervention. Finally, the pandemic poses a significant threat to the already extremely precarious financial situation we have in terms of funding for harm reduction. We know 2 things. Firstly, at the end of 2020, we're going to be almost 90% short of the estimated $1.5 billion required annually for an adequate response to harm reduction. Secondly, the largest donor for harm reduction is still the Global Fund. The Global Fund and all other donors in the harm reduction space have also faced COVID-related disruptions, and funds are spread thin. In this context, it is essential we continue to call for investment in harm reduction at every level, with every government official and every donor, as well as in our advocacy and engagement with the development of the Global AIDS Strategy and the upcoming United Nations General Assembly high-level meeting on AIDS and its political declaration. While we know that drug use and harm reduction are not solely about HIV, the limited resources available are frequently connected to HIV. Finally, while we are still understanding the full extent of how COVID has affected people who use drugs and harm reduction services, there are 3 things that are clear from our data collection and the research of our partners around the world. The first, community leadership has been transformative. Peer networks were online and out on the streets, solving problems in their masks while everyone else was still learning to use Zoom. Input in the European network of people who use drugs were the first to develop guidelines for people who use drugs, now available in 20 languages, and to publish harm reduction tips to support people to avoid COVID in the context of drug use. Amongst the pain and fear and chaos which has characterized 2020, people who use drugs have led with courage and compassion, demonstrating the case for community leadership yet again. Secondly, lockdown measures combined with criminalization and over-policing have impacted the most vulnerable hardest. It's only going to get harder to reverse the entrenched injustices associated with how the poor and marginalized are treated in society. Disrupting this must be core to our work. Thirdly, in the context of global upheaval, governments and civil society have found new ways to reach people, from secondary syringe distribution to take-home doses of OAT to phone and video consultations, creating important momentum for the permanent acceptance and adoption of health interventions which place human dignity, agency, and lived expertise at the center of the response. To my final slide. A few hours ago, we received the news that Dr. T had a family emergency and won't be able to join us today. So I'm going to share this quote from her forward to the Global State of Harm Reduction. I know it's not the same, but I think that we can all appreciate that 2020 has been a year of unexpected events. It's been a real honor to work with Dr. T on the forward to this year's Global State. Her expertise and her perspective on the connection between bodily autonomy, the right to health, and social justice are going to bring like an exciting and fresh new frame to the mandate. And as she states in the forward, made painfully clear that until we ensure everybody can enjoy the right to health, we will not be a thriving society. So today we're incredibly fortunate to be joined by expert partners, authors, and contributors to the Global State of Harm Reduction. I'm going to introduce everybody, then turn to Colleen to lead our Q&A. First, we'll have the Q&A with the experts, and then we'll open to the audience. If you do want to ask a question, pop your question in the question box, but also raise your hand so it's easier to pull you out of the participant list so you can ask your question. So first, I'm really pleased to introduce Colleen. Colleen joined us this year. She's our Deputy Director and Public Health Lead. She has 23 years experience from diverse places around the world as a director, project manager, and technical advisor in HIV/AIDS, TB, gender, human rights, and community system strengthening. Colleen has worked for the Stop TB Partnership, the World Health Organization, Treatment Action Group, Health Action International, and the Tongan and Australian governments. Among these roles, Colleen has worked to catalyze global leadership to accelerate momentum towards universal access for high-quality TB and HIV services, and developed and implemented campaigns and advocacy strategies to accelerate TB/HIV service delivery in developing countries. Colleen will be leading discussion with four panelists actually. Dr. Gideon Lasco is the author of our Asia chapter. Gideon is a physician and a medical anthropologist. He's a senior lecturer at the University of the Philippines Dillamans Department of Anthropology and a research fellow at the Ateneo Development Studies Program. A recipient of the Palanca Award for Essay, he maintains a weekly column on health, culture, and national affairs in the Philippine Daily Inquirer, as well as a newly launched column in Sapiens. Gideon's current research projects include studying medical populism during times of health crises, documenting people's evolving perceptions and practices during COVID-19, and analyzing the impacts of the drug wars in the Philippines and Asia. Anna Dovka is the Executive Director of the Eurasian Harm Reduction Association. ERA unites 303 organizations and activists from 29 countries of Central Eastern Europe and Central Asia to advance progressive human rights-based drug policy, sustainable funding, and quality services oriented to the needs of people who use drugs. Anna is originally from Ukraine and is known in the region as a community mobilization trainer and expert, has extensive knowledge of health and social programs in organizing capacity building systems and social research, as well as in leadership to support civil society organizations and activists. And you can see Anna, we're lucky today to be joined by Maria Plotko, who is the author of the Eurasian chapter. Maria is a senior program officer with ERA, a sociologist by training, with 7 years experience working across non-governmental organizations, both in think tanks and other organizations engaged in the education of and in providing assistance to representatives of socially unprotected groups. Finally, Dr. Jorgelina de Llorio is the Intervention Programs Coordinator at Intercambios in Argentina. Paulina is involved in writing our Latin American chapter this year and in the past, and is a social psychology professor at Buenos Aires University and a researcher at the National Scientific and Technical Research Council. Her work advances understanding at the intersection of urban poverty and health and mental health, and focuses on homelessness, action research approaches, and peer-to-peer methodologies. Thank you so much, Colleen. Thank you for being with us today, everyone.
Thanks, Naomi, and thank you so much to everyone for joining us today. We're really excited about this. I was saying that, you know, with our team, we've been working on this for 9 months, and everyone has been so engaged and working so hard. I could have made a human in that time. So this really is one of our really big projects, and we're excited that everyone is here. We wanted to take a little bit of a different approach today in terms of letting you know what's going on, what some of the data that we found and some of the things that are happening on the ground in the various regions. So as Naomi said, if you do have a question, please pop it into the Q&A box and raise your hand so that we can track you and we can come to you after our questions here. So one of the things that we found in the report is that progress in harm reduction and evidence-based health responses to drug use is at risk as more punitive policies proliferate in regions across the world. And we're also seeing that a lot of legislation and policies related to COVID-19 is also impinging on human rights and in other areas of our lives. So I wanted to go to Gideon first and talk a little bit about, Gideon, asking you to talk a little bit about how have punitive environments in the Asia region directly impacted people who use drugs and the adoption and scale up of harm reduction approaches? How does this impact the fulfillment of the right to health for people who use drugs?
Thank you, Colleen, and greetings. A good evening to everyone from Los Baños, the town of Los Baños in the Philippines, where I am joining you this evening. It's a stormy night in the Philippines, but I'm definitely heartened to be with all of you now. It's really an important report, and I'm really honored. Thank you for inviting me to be part of this. So, Colleen, you brought up something that is really of the essence in the region when we talk about harm reduction and drugs. Although, of course, Asia is a very large region, so some of my responses might be a simplification, and there's so much more in the report. But the short answer is it's definitely made it much more challenging to push for services and even for the paradigm of harm reduction. We have politicians all over the region, particularly in Southeast Asia, who are averse to any kind of harm reduction paradigm whatsoever. And harm reduction groups and also human rights groups, instead of fighting for the right to services, we're basically fighting for the very lives of people who use drugs in the Philippines and other parts of the region. You would think that the pandemic would have interrupted the war on drugs, but I am sad to confirm that it's ongoing today, and many people are still getting killed, especially in urban poor communities, because of, in the name of this drug war that's largely hypocritical and involves planting of evidence and many other atrocities. But beyond that primary concern that we all have, there are also other consequences of these punitive regimes. For example, coming up with accurate data has been very difficult, as we've seen in trying to assemble the numbers in the harm reduction in the report. In the first place, there's lack of prioritization for coming up with data regarding drugs. And at the same time, there's also a political imperative for some leaders to exaggerate the so-called drug problem, and they end up exaggerating the number of what they call addicts or drug dependents, even though if you look at the data, it's actually, there's no basis for those numbers. So there are a lot of various consequences. And I would also just like to quickly add the fact that over 400,000 individuals in the region are living under forced rehabilitation and compulsory detention. Some not in name, like technically it's rehab, but it actually is forced rehabilitation and compulsory detention. And we have seen infections, also so COVID is such a concern as well. So despite growing evidence, of course, that voluntary treatment is the effective and humane paradigm, this continued to be the major treatment approach in the region, with Singapore even extending the maximum detention period in rehab centers from 3 to 4 years. So, and this is characterized with inhumane, many of these are characterized with inhumane conditions. So in terms of the impacts, definitely, I can say a lot, but those are just a few of the things that we've seen.
Thank you so much, Gideon. I'll come back to you with other questions, but I just want to talk a little bit about funding. One of the things that we found in the 2018 report was that funding in low and middle income countries amounted to about $188 million, which was only 13% of what UNAIDS estimates is necessary for adequate harm reduction responses. The global COVID-19 pandemic poses a threat to the already precarious funding situation for harm reduction. And at the time of publishing the report, harm reduction appears to have lost a major international donor, with the Dutch Ministry of Foreign Affairs not renewing its bilateral support. And they're doing this under the auspices of a shift in funding priorities from HIV to sexual and reproductive health. And, you know, the Global Fund to Fight AIDS, TB, and Malaria still is the largest donor of harm reduction. And in 2019, harm reduction advocates around the world joined calls for donors and governments to ensure a successful global fund replenishment. And so, Anna, I would like to come to you to just ask you to give us some examples of successful and unsuccessful donor transition in the Eastern European and Central Asian region. What are some of the consequences and what are the lessons that we can learn?
I would say that our region, together with Latin America and with MENA and Southeast Asia, we are facing the ever-increasing gaps in funding, and this shifting of priorities from middle-income countries, it's coming simultaneously by Global Fund and all other contributors to Global Fund, like 5% initiative Dutch funding, and it's coming this last 2 years. It's cutting all the funding for services. In the same time, I would say some countries really are going very good in transiting to domestic funding. And we are lucky to say that during the last 2 years, the call for proposals for harm reduction for needles and syringe exchange programs started in Kyrgyzstan from domestic funding, in Georgia, in Ukraine, in Moldova, in Northern Macedonia, in Montenegro. And all these countries are starting to support finally the social work in addition to administrative facilities or to the opioid substitution treatment drugs. And what we face as a challenges, first of all, when state, even if state is funding some harm reduction, they invest much more in imprisoning people. And we have this criminalization cost map showing that it's up to 10, 15 times more invested in imprisoning and criminalizing people. And for harm reduction, it's always not priority for the state, unfortunately. In the same time, there is the optimization of unit cost for the services. And even if the standard is staying, it's a number of services, and you need to train the outreach workers, and you need to provide psychological support and social support and adaptation and legal support. In this situation, state is paying only for medicalized services or only for a limited number of syringes, needles, and some very limited facilities to test on HIV or test on hepatitis, and that's it. And the quality and the unit cost of the package of harm reduction services, coverage, geographical, and the level of coverage by the services, it's the biggest concern in Eurasia region. We are not even having 20% of coverage of estimated number of people using drugs in the region. And that's really influence the epidemic situation with hepatitis, with TB, with the HIV, but it also bring more challenges in lives of people who use drugs. And with COVID, when harm reduction services really sustained their work and sustained provision of the basic services, we found that people who use drugs on the street, they need shelters, they need more non-HIV related harm reduction.
Thank you so much, Anna. And I think that is also reflected in the types of services that people are able to provide. And so I think this moves really nicely into looking at some of the key issues that Jorgelina has faced because in much of Latin America and the Caribbean, injected drug use is uncommon, with smoking the preferred route of administration for crack cocaine and cocaine paste. There are actually, there are approximately 5.5 million people who use non-injected drugs in Latin America. And the number of people who inject drugs is actually quite low compared with other regions. Non-injected drug use is less associated with blood-borne disease transmission, and in some cases can be an alternative to injection, which reduces the harms associated with injecting drug use. However, what we found is there remain significant health risks associated with smokable cocaine. And one of the issues is that transition to domestic funding applies primarily to services for people who inject drugs. And there are few funding opportunities for services for the majority of people who use drugs in the region who do not inject. So Jorgelina, I'll come to you. What harm reduction interventions are available for people who use stimulants or use drugs and do not inject? And what changes have we seen over the past 2 years in the Latin America region?
Okay, first of all, we need to understand why in Latin America there are non-injector drug users are more common than injector use, and this is not new. This is a trend that we are seeing in the different reports from many years before. It's not something new that we found in the region. And one of the things to understand this is, first of all, that Latin America, especially South America, is the primary producer of cocaine of the world. So it's also it's cheaper. It's cheaper for users to smoke cocaine. So this is two aspects that we need to, from the context, to understand these patterns related to drug use in Latin America. And most of this, that's one of the reasons we didn't found NSP services or OAT provision in Latin America, not because of the lack of funding, because the reason is that there are no drug injectors. So most of the services are for smoke cocaine or stimulant users. We have different programs in Argentina, in Colombia, also in Puerto Rico, in Uruguay, some services. For example, in Argentina, we have what we call casas de acompañamiento, sorry for the Spanish, but it's a specific program that is also supported by the government that supports non-injector users, specifically smoke cocaine users. Also, we have some programs in Brazil, like with the ley, las casas de convivencia. And in general, these programs provides not specifically safer smoke equipment. There is only one experience in the region in Puerto Rico that provides this kind of equipment to non-injector users. In general, the services provide health services, food services, legal advice, also trying to reduce violence and discrimination for non-injector users in the regions. So they focus on different kind of vulnerabilities, because this is, in generally, this is a kind of use more common for marginalized groups, and also it's really difficult to collect some information from them because of these characteristics. And some of the services, also many of these programs distribute condoms, and also they have HIV tests and viral hepatitis tests in these programs. And we think this is something really important from the services. And some of the changes we found in these reports are related with most of the programs closed because the more conservatory administrations in the regions have a regression toward more punitive approaches. So this affect the foundings and the services. So many services have closed, and also those who are open reduce their coverage. And this is something that also in Colombia and Mexico and Bolivia and Brazil and in Argentina, we found in this report. Some other thing that we found about the changes in the programs is related with these military approaches to the kind of response to the use in Latin America, especially in Bolivia, in Ecuador, in Peru, and in Colombia. So fundings goes to this kind of response instead of these harm reduction services for also more incarceration for people who use drugs. And we think this is a problem that is increasing in the region.
Thank you so much, Jorgelina. I'll come back to you, Gideon. And from the research that you did you see any best practices where harm reduction approaches positively influenced a country to move away from punitive environments?
Well, I want to highlight in relation to that, Colleen, that what we've seen as really a significant finding in the region is the rise of methamphetamine and NPS use that's creating different harm reduction needs in the region. So, and I think Nick highlighted that also in a question. So, and what we've seen is that it's very slow because of the attitudes towards methamphetamine in particular. So what we're seeing is that people's attitudes and politicians' attitudes towards drugs is not homogeneous, that it's just drugs. People have different attitudes towards methamphetamine in particular, which I think has to be highlighted. So there are some countries that have moved towards reforms in cannabis, but when it comes to shabu, what we call shabu or methamphetamine, yaba in Thailand, there's a lot of negative attitudes, and that's getting in the way of these programs. Although we have seen some pilot programs of harm reduction, particularly towards people who use methamphetamine in Indonesia in particular. So we've seen this Charisma, a Jakarta-based NGO, make this program that includes distribution of safer smoking kits, plastic straws, accompanied by harm reduction education and access to services. And I think those pilot programs have the potential to change the attitudes of leaders, both at the local level and the national level. It's easier to deal with the local level at first. So those are the things that we've seen. And at the same time, in Myanmar, we've also seen some legislation that leaves the door open for certain reforms to happen. Now, very quickly, I also want to emphasize that given the political sensitivities involved in drug issues in the region, there are some programs that are harm reduction in name, but not in practice. But at the same time, there are also programs that are actually harm reduction in practice, but then it cannot be named as such to avoid sensitivities. So we're seeing both of that in the Philippines, where the HIV law, they managed to insert some provisions that can enable for services that are harm reduction. But at the same time, we see governments calling different kinds of programs as harm reduction when in fact they're actually referring to forced rehabilitation. So we need to be really very nuanced and very critical in the way we look at these policies, because sometimes they don't really mean what they say.
Thanks, Gideon. And I think that's going to be really key moving forward now, where we have next year, where I'm sure we're going to see smaller budgets, less prioritization of harm reduction. And so being able to really have a nuanced approach to what is harm reduction is going to be important. You know, I think to date, we've seen harm reduction as needle and syringe programs or opioid agonist therapy that have been added to HIV programs. And so one of the things we might want to consider moving forward from some of the research we've seen is, what is harm reduction? What is integrated service delivery? Well, to me, if we're going to look at people who use drugs and look at it from their point of view, then services should deliver what people need. So it might be that they need HIV, tuberculosis, hepatitis C services. It might be sexual and reproductive health services. It might be services related to people who might be experiencing homelessness or gender-based violence, because a lot of the times women who use drugs, and we've seen examples of this in the report, are excluded from services. And so we need to be able to look at all the different nuancing and subtleties that countries are using in terms of program implementation to ensure that we get that breadth and depth of services that a person who uses drugs needs. Anna, as we're talking about funding, what can international donors do to make sure that sustainable domestic funding is in place when they withdraw from a country, on top of sustainability and transition policies?
Actually, that's something which I wanted to say. Very good transition documents in majority of countries of Eurasia doesn't mean the real sustainable funding for harm reduction, unfortunately. If one country, the biggest country of the region, will ban opioid agonist treatment and introduce foreign agent law and introduce law on unwanted organizations, then we could do nothing with other countries. And unfortunately, this law on drug propaganda, which all harm reduction information sharing through internet could be named as a drug propaganda in Russia, Kazakhstan, and there were some initiatives in Ukraine. That's very dangerous actually for us. And what donors could do, it's first of all introduce the data collection and continue data collection. Sorry. Because we need to know the drug scene, we need to know health of people, health consequences of people using drugs. Donors need to invest in advocacy for decriminalization and overcoming legal barriers, because with criminalization, all our funding will sit in the budgets, not in the help of people. Sorry. And we need to invest in health and community systems to allow sustainable funding. We are not standing alone, and harm reduction need to be integrated in the healthcare and in the social care and in universal health coverage. Actually, that's something where we need to put harm reduction into agenda. And nobody except the international donor could support development of community movement and support watchdog function for budget advocacy, for advocacy to protect human rights and to protect organizations who are providing services.
Thank you so much, Anna. I think, one of the things that we have seen in the response to COVID-19 and harm reduction is that civil society and community-led services are so critical. As Naomi mentioned, if they didn't step in, a lot of services would have actually just abruptly ended, and we wouldn't have had continuation. So, Jorgelina, in terms of some of the countries like Colombia and Brazil, what can we learn from civil society-led services in those countries where the government is increasingly opposed to a public health-led approach to people who use drugs?
Drug policy development in Latin America is not homogeneous, so that's one of the reasons civil society also has a different kind of development in the region. But in general, civil society in Latin America and the Caribbean is huge, is big. There are a lot of local networks and also some regional networks that works or advocate to decriminalization for drug use, less strict sentences for the level drug crime and drug policy, focus on health outcomes and harm reduction. So I think that in all the region we find different kind of a network of civil society organizations, specifically in Brazil and in Colombia. In Colombia, Temblores is a civil society organization that is highlighting the disproportionate enforcement. So they are working a lot, trying, even in Colombia, possession of drug is discriminalization. They increase different kind of punitive activities or policies. So civil society is highlighting and advocating for changes in drug law legislation. And in Brazil, we think that the situation is really hard because the Bolsonaro administrative and more conservatory government really affect the harm reduction services, not only with the lack of funding, also with criminalization and increased violence in all the region, not only for drug use. So civil society specifically is working to denounce and to highlight this human rights violation for people and the lack of services. So there are like RENFA and Aborda, different kind, La Escola Libre of harm reduction, different civil society initiatives that are trying to highlight the situation, the human rights violation and the increased violence for drug use in the region. I think that in general, in Latin America, civil society is organized, and also specifically in Brazil, many harm reduction organizations from the region were working in a kind of conference that it would happen, sorry for my English, last month, but due to the COVID response of the governments, they haven't any fundings to do this activity, but it will be a kind of conference that showing different civil society organizations from the region, from Colombia, from Brazil, from Argentina, and from other countries, trying to denounce these more punitive approaches of drug policies in Brazil.
Thank you, Jorgelina. I think it's really important that we do start to highlight. I've seen some of the questions in the Q&A box. We'll come to them at the end, but definitely be able to highlight the importance of civil society and how they can actually bridge that divide between government policies and government approaches and the needs of people who use drugs. In terms of that, Gideon, what other important developments have taken place in the Asia region in the last 2 years to enhance the protection of the rights of people who use drugs?
Well, Pauline, I also want to highlight one of the really unfortunate developments that are taking place involve women in the region. So I also saw in some of the questions that people are asking for what about the intersectionality of what we're talking about. So I want to highlight that women have been in particular in the receiving end of human rights violations. In one IDPC supported study, for example, they found that 17% of women who are deprived of liberty in Thailand actually say that they were compelled to admit crimes that they did not commit, and they didn't have access to all kinds of services. And also in the drug wars that are happening, we see that women are particularly vulnerable as well, despite our image of the drug war being towards men, but actually women are vulnerable, with reports of sex being exchanged for freedom or for lesser charges for their family members. So we're seeing drug war widows that are turning to sex work and other precarious income opportunities in countries where these have been conducted. But at the same time, in terms of policies, we're also seeing certain reforms, however incremental and however minimal. For example, we see South Korea being the first country in East Asia to legalize the use and cultivation of cannabis for medical purposes. And then Thailand also had some legislation that involved not just cannabis, but kratom, which is an NPS of great significance in the region that I think should also be a priority in terms of harm reduction needs and looking at it more broadly beyond injecting drug use. So for a while, the Malaysian government also started to talk about how they want to do judicial reforms, including decriminalization. But I don't know now with the new government how this is playing out. And then we also saw Myanmar having a national drug policy. So at the individual national level, we see some kinds of bits and pieces of reforms. And at the same time, despite the seemingly punitive environment happening in places like the Philippines, this has also served as an impetus for civil society groups whether in Indonesia, in India in particular. We have very active organizations who are using these punitive steps as an opportunity to to challenge it, and because there's media attention and political attention. So that is all. So it's not completely negative in the sense that there are groups that are speaking out and then they're collecting data, doing research, some quietly, some doing harm reduction work that actually requested not to be mentioned in the report because they fear that it will interfere with their activities. So even though I'm here in the Philippines, I do not completely feel pessimistic given what these groups in the region are doing.
Thank you so much, Gideon. Anna, I think related to that, how can civil society and communities actually work with governments or local authorities to ensure sustainable domestic funding in their country? Are there any success stories from the region?
Actually, there were during the COVID, there were very good development. It's opioid agonist treatment, take home introduction in some countries of the region. And this happened because of the previous advocacy, and it's also bring doctors to understand that it's very good way to optimize services, not only in lockdown, but after. Not all the medical services, medical doctors and authorities understand this. And I agree with Ola Bilaeva from Input, who's commenting on OST in hospital setting, in medical setting for those who are treating COVID, it's not available now. And we see in this situation that our agenda is going much faster than we could arrange through the advocacy and change the services in order for the services respond to the needs of people who use drugs. But still, this involvement of community leaders into the country coordination mechanism or country systems who are watching how health is working, any coordination bodies, we are really investing a lot into budget advocacy skills of the civil society organization and community leaders for us to be able to check budgets, to influence political and financial decisions, and to make the community-led monitoring and of the quality of services and availability of services and funding for services. That's only what we could do in this circumstances, actually. But we see from the region that even small investment in community based organizations and in community networks bring a lot of results. And actually, that's one of the outcome of all harm reduction advocacy, that we can't do this without community, and we can't avoid supporting community in this advocacy.
Thank you so much, Anna. I think we've got so many questions that are coming up from the audience, so I'd like to get some time to be able to get to them. So if we can move to the first question from Annette Gaudino. Annette?
Hi, yes, I was wondering if the panelists could briefly address the impact of police enforcement on quarantine mandates and social distancing measures in their regions, and if anything is being revealed about the role of police with regards to COVID response.
Thank you so much, Annette. I think I'll actually take another question on COVID. So if I could put a few questions together, that'd be great. So I'll go to Josephine Adipo.
Yes, my question is on the effect of COVID on the world economy, because I heard one of the speakers saying that there's been a shift in funding from the global fund contributors. So what role can activists play in ensuring our governments devote more funds towards harm reduction, especially in the face of COVID-19 and how it has affected economies?
Thank you so much, Josephine. So I'll just get the conversation started, but one of the things in terms of COVID and policing that we did see was that physical distancing and capacity and availability of services obviously decreased. Opening hours decreased in the long term, but what's happened is that police monitoring and the expansion of the police role and lockdown rules has made it extremely difficult for people to travel. For example, on public transport to get opioid agonist therapy. We know that from parts of sub-Saharan Africa. In South Africa, where opioid agonist therapy is done as directly observed therapy, those services actually had to decrease or cease because of lockdown rules, where people couldn't be out on the street or they'd be arrested or given fines. But I'll come to Jorgelina and or Ghana and Gideon to see if any of you would like to answer about what some of the things that you found in the regions. Anna?
Yes, with the COVID, we did a specific round of calls with the members of association, and we find out that, first of all, we all see that harm reduction organization playing much more role than just HIV response during the COVID. So it's a COVID testing, and it's referral to the clinics and help to the migrants to get RT. Delivering RT together with opioid agonist treatment drugs, delivering more harm reduction tools to people, and providing any help which people need, sometimes shelter and food packages, and legal help in the case when really police actions are criminalizing people who use drugs even more for COVID or being on the streets. And in this role, I see that harm reduction organization, it's organization who could, in this emergency situation, show to the local authorities, and it's really on the local level, it's very vivid. You could see it easily what organization keep going, keep providing help, and what help could be provided. And our understanding of harm reduction with the COVID became broader as a help, any social and health support to people who use drugs. And in this case, we think that we could change a bit the language, because the harm reduction, it's not only HIV response, and funding for harm reduction need to go from other sources, not only HIV response. And that's an important point, especially when COVID is priority and all other health threats are not. And with the what is important outcome from lockdown, it's a changing in drug scene. And that's why we are highlighting the need for states and for donors to invest in research of drug use and health of people using drugs in regular research, because and nowadays it's more and more important with the changing drug scene and changing needs in the harm reduction services.
Jorgelina?
Now, all in Latin America is not homogeneous. Not only the civil society organization, not only the drug policies, also the COVID response in the region is not homogeneous. So we can say that we find similar things that Ghana says related to the police force or the police control of people on the streets, not only drug users. So there are a lot of denounce of the incarceration, and also some violence increase on the streets during COVID-19. Also, there are a lot of barriers. We found a lot of barriers for users to continue their treatments, those in case that need the treatment, not only because of the social distancing, also those vulnerable groups that they were put in some places, some accommodation, close accommodation in general. We found many barriers to access to their treatments. And one thing that I think is really important in Latin America response is that some harm reduction civil association provide protection equipment, masks, and equipment, also food and accommodation to drug users. And I think that many of the COVID response for users was a guarantee for civil society or organization. But I think that some structural violence related to accommodation, to help to access to health and other rights, that the problem is not only drug users. We found a huge problem related with COVID, the impact of the COVID-19.
Thank you. I'll just come back to Josephine's question around financing. I think one of the ways that we can actually talk to governments about harm reduction funding would be to show some of the success stories that we've had, particularly during COVID, and to be able to show that it is actually cost effective, and by having cost-effective interventions, you'll be able to save money over the long term. And I think we need to be able to use some of those arguments when talking with our governments. Gideon, do you have anything to add to how we can, how we can advocate for harm reduction funding to be maintained and increased?
Well, the overall attention to health as a priority that's brought about by the pandemic can potentially be used by advocates to demand for more access to services to make it a health issue. So, for example, I know that in some Southeast Asian countries, there is an attempt to push for reforms in the justice system because of the overcrowding in jails, mostly because of drug-related offenses. So it's suddenly now become a public health issue as well, that we have all of these people in inhumane conditions because of overcriminalization and actually wrongful arrest of so many people. So I think that we may have to be strategic in the way we achieve our goals, that it's not necessarily, we may have to compromise the name harm reduction, but the idea will be there, and make it thrive in different streams of government, whether in the ministries of justice and health and other areas, to achieve similar goals of improving the health and the human rights of people who use drugs.
Thank you. We have actually a few questions around prisons and services in prisons. So if we can have Emily Christie. So Emily, if you go first, and then we'll have Kunal Kushore after.
Sure. It was a very simple question. It was just the research that Gideon referred to about women in prison in Thailand being forced to admit to crimes they hadn't committed. We would love to have the link to that data or research or a way of finding it.
Oh, absolutely. I can share you the link right now. It's actually based on a policy guide for Thailand developed by Ozone Foundation and IDPC. So it's credit to them, but it's widely available and in our report, but also I can share you the link right now that identifies not just that, but also other very, very negative picture of what's happening in the Thailand, and not only in Thailand also, but there's also some policy guides developed by Cathy Alvarez in Indonesia and the Philippines as well. So there are 3 documents that are available, and I can share you the link.
Thank you so much. That'd be great.
There's also one question from someone without a name. What have been the most significant changes on harm reduction in prisons? Are there best practices that should be highlighted? Anna, do you want to take this one first?
Actually, in our region, the harm reduction prison just introduced, so we couldn't say that it is really good practices. And we are happy to say that, yes, we have new countries who are introducing opioid agonist treatment and NSP in the region, but it's just the pilots, unfortunately.
Jorgelina?
Asian population in Latin America is increasing also because because we need to advocate for the criminalization of the possession of drugs. Sorry, we have some HIV testing services and also viral hepatitis services in prison, but related with drug use, we don't have any harm reduction services. We found, I would like to highlight a specific experience program from a harm reduction society in Paraguay, Enfoque Territorial, that they implement a pilot program in Asunción prisons, but it was closed recently because of lack of funding. But I think it's important to highlight these kind of experiences. But most of the problem with harm reduction in prison is that in Latin America, we'll still have, we need to advocate for decriminalization for users and also changing in law legislation. I think, nothing, sorry.
No, that's so true. And I mean, unfortunately, you know, very, very sadly, we haven't seen much progress in the availability of harm reduction in prisons. I think there was just one sort of, you know, a highlight that stood out in the report where Canada opened the world's first prison drug consumption room in Alberta in June 2019. So this is one positive step, but you know, a drug consumption room is not a replacement for an effective prison needle syringe program, for example. And so in terms of the advocacy that needs to be done, we really need to be talking about the right to health for prisoners. And that includes harm reduction, and it includes, you know, addressing TB, HIV, hepatitis, and so on. And it's just not being done. And I think, you know, Harm Reduction International did some monitoring of prisons during COVID and some of the policies in terms of prison releases. And it was really disheartening, as Naomi mentioned. And so, you know, there's this opportunity, and I think I'll take Karen Kaplan's question now about how do we have these intersectional movement building across different areas. Karen, are you there? Yep.
Yes, thank you so much, Colleen, and to all panelists for a great panel. Yeah, I was just wondering from the perspective of optimizing our power and resources in such a repressive an under-resourced environment. That doesn't look like it's getting better anytime soon. It would be wonderful to hear from the front lines in different regions how, if and how, and I know Gideon began to speak about this, different movements are coming together around common issues like criminalization. Thank you.
Gideon?
Thank you for that. I think it's essential to, what we're learning is that it's essential to act on different levels in terms of engagement. So the national government is not just the actor here. We have local governments, and sometimes they're actually much more open to the national government. But at the same time, we also have regional level governments, including in Asia, there's a South Asian Association, and at the same time, there's ASEAN for Southeast Asia. And as a region, there are definitely possibilities for collaboration at that level to be able to assert. So actually, Harm Reduction International has been very active in releasing statements about the Philippines. And I really appreciate that, because those statements mean a lot for here. For these joint statements that you put up, these are not meaningless at all. They get reported by the media as an international attention towards the drug issue. So at a time when local advocates are getting burned out and getting tired of speaking out about these topics, the role of international agencies and organizations definitely mean a lot. And also the role of academia as well. So we've seen in the region, there was recently last year a conference organized by ISSDP in Hong Kong to bring together advocates and scholars in the region. And I think that was really a wonderful event where people felt empowered and realizing that they're not alone in facing these similar issues. So there's so much potential out there, and there are efforts by different groups. I think ANFUD and other organizations in Asia are moving towards building these coalitions, and we definitely see the value in that. And unfortunately, it's been deferred due to the pandemic, but I really look forward to be part of these because I think that they really mean a lot.
Thank you so much. And I'd like to, Anna, just before I come to you, if Kunal Naik, if he's on, yes, Kunal. Kunal was actually one of the co-authors of the Sub-Saharan Africa chapter and does a lot of work in French-speaking Africa. Kunal, can you also respond to Karen's comments? A question?
Hi, can you hear me?
Yes, we can. Thank you.
Can you just repeat the question? Can you just repeat the question Karen asked?
Yeah, sure. So she was actually asking about how could panelists talk about the developments in intersectional movement building in their regions, in light of paltry funding, lack of political will, devastatingly bad legal environments for people who use drugs. How can advocacy positively change this approach? And how can we actually, bring different groups in together to respond?
I mean, for Africa, one thing that actually can be of great help is the African Union Plan of Action, which actually has been has actually mentioned harm reduction for the first time, and it's sort of a plan that countries can adopt, and advocates and activists can actually look towards that plan and use it as a lever to actually convince their governments or policymakers to start introducing harm reduction services. I mean, from the data also gathered in the harm reduction report, we can see that there's major gaps in funding as well. But the major problems with that is basically the political climate and the unwillingness of countries to adopt harm reduction as a measure, even though it's been mentioned in the EU Plan of Action and also it's proven to work. But I think that we are sort of going towards a positive trend, especially when you look at countries such as Burkina Faso, who introduced opioid substitution therapy, and Mali as well, looking towards actually expanding services that they started on a pilot basis. Obviously, there's a lot of work to be done. And again, the major concern for Sub-Saharan Africa is the lack of reliable data. As you will probably see in the report, there are major gaps that will not be, if not addressed properly, will not give us the right tools and right means to start developing programs and also be able to advocate for harm reduction services to be included in what's offered in terms of drug use.
Thank you so much, Kunal. Anna, and then we'll start wrapping up.
I would say that at a very long time, we were speaking about harm reduction as a medical or social intervention, forgetting about the legal help, which need to be included inside. And now we are, in our region, we are developing together with different vulnerable communities like sex workers, LGBT community, MSM, transgender, and people who live with HIV. We are developing the legal services or paralegal services to support, to overcome legal barrier, not on political level, but in everyday life, and protecting rights in the case of violence, in the case of police catching and arrests. And that's one part, it's a service part. But other part about decriminalization, we do need the to build more broad understanding and movement of health professionals, of other communities in the countries and regionally, that without the decriminalization of using and possession of drugs, we can't build the effective harm reduction and effective health system for those who are marginalized. And in this case, I need to scream, and you've heard, most of you heard this, chase the virus, not people. This slogan and this campaign was developed by 9 different regional networks, including sex workers, MSM, transgender, LGBT, teenagers living with HIV, and women living with HIV. And we all together managed to highlight this barrier, the criminalization and stigmatization, as a key barrier to HIV response. And now I'm happy to say that European hepatologists recognize criminalization as a key barrier for their services and for elimination of hepatitis C. So we are moving step by step, moving to understand to the understanding that without criminalization, without decriminalization of use and possession of drugs, we can't be effective in the universal health coverage.
Thank you so much, Anna. I see more questions coming, and I wish we had more time to be able to get to them, but unfortunately we're running out of time, so we're going to have to wrap up. But I just want to say thank you so much to all of you for being here today, for supporting this, and especially to our panelists. I also want to mention that Chris Baguma, who co-authored the Sub-Saharan African chapter, is also on the call. And so in the report, you will see all the authors, and you can reach out to them individually or through us. Please get in touch if you have any questions, if you have any clarifications. We're here to answer that. I also want to just acknowledge one more time Robert Cizek and Sam Shirley Bevan, who honestly kept me sane during this process. Their extreme professionalism and fantastic writing and research has just made this report something that is going to be really useful for all of us. I think, with this report, some of the advocacy areas that we really need to work on are redefining harm reduction, because we're doing so much more than just needle syringe exchange and opioid agonist therapy. We need to be able to push for normative agencies like the World Health Organization to get us better data on people who use drugs when it comes to tuberculosis or hepatitis or HIV. We need to be able to acknowledge the extreme and in extreme circumstances, the efforts of civil society over the past 2 years to be able to really hold on to the harm reduction services that we do have, but to also expand them so that everyone who uses drugs and needs these services can access them. And lastly, without funding, these services will not happen. We know that. We've seen it in Eastern Europe and Central Asia, in countries that have transitioned from Global Fund, for example. If we do not keep pushing our governments and our donors to ensure that people who use drugs are seen as equal to everyone else, they have the same rights as everybody else, that they're just people who have another issue to deal with. And we all have tons of issues, right? We all have a lot of things going on, but we're not as stigmatized and discriminated against as this particular group. And so this is something that I think is so important that our speakers have also talked about, is that ensuring our funders and our governments understand we're talking about people. Yes, we would like to also talk about the number of syringes people should get, but at the end of the day, it's about a person and what that person needs. So thank you so much to everybody. Thank you, Gideon, Ana, Jorgelina, and thank you, Naomi, for being the captain of this massive ship that's moved this year. So please do get in touch with us if you need anything. We thank you all very much. Bye, everyone.
Thank you.